Okay, class, welcome back. In this lecture, we're going to discuss acute pulmonary conditions. So, just kind of continuing on from our previous lecture, so we had covered all the chronic conditions, so obstructive and restrictive defects, our pulmonary hypertension, lung cancer. In this lecture, we're going to talk about the things that can occur acutely to the lungs, to the vasculature, as well as to the pleura. And then some unique clinical conditions that may ensue even from treating the lungs. So, as a reminder, any of these acute conditions can occur in patients with chronic lung conditions, as well as even just healthy individuals. And some of these you might be more familiar with. So the first one we'll talk about is atelectasis, which is small airway collapse. This is a pretty common condition. It's not super concerning. Typically we see this after surgery or anyone who's just not moving around and ventilating their airways too effectively. If people have secretions, like we see with COPD, or more mucus plugging, or if someone's on anesthesia, we talk about how that affects the mucociliary escalator, we can get this temporary collapse. But as you guys remember, we have those type 2 alveolar cells which produce surfactants. So if we give ourselves a couple good coughs, maybe some deep breaths, or walk around, those typically clear up. So patients may have a little bit of a fever, maybe some tachypnea, maybe breathing a little bit fast. They typically don't get dyspnea. You may also hear scattered rales. And we'll cover what this sounds like in our chest examination lecture. But basically, it sounds like Velcro. If you ever, have played with Velcro, but it sounds like Velcro being pulled, kind of a crackling noise. That's why they're also called crackles. Over the segment where there's atelectasis, you may hear some decreased breath sounds. But again, this is a fairly benign condition. It's a temporary condition. Again, we see it's not too uncommon to see it after surgery. Again, in obese individuals as well, or anyone who's just not really ventilating too well in their segments, to their lung segments. The bases typically are affected more than the upper segments, due to some of those changes or differences in perfusion. We talked about the hydrostatic pressure. Now, atelectasis can be concerning if it persists for a while, if we don't really ventilate, and we'll talk about kind of why in a bit. And it can potentially lead to the risk of developing a pneumonia. And we'll go over, kind of what that looks like in a bit. But again, it's easily preventable by taking full breaths, 10 an hour. So if you're sitting around listening to these lectures, make sure you break it up, walk around a little bit, stay active, mobilize, take some deep breaths. And that's why we see patients utilize those incentive spirometers to really encourage patients, especially after surgery, if they're going to be in the hospital for a while and not moving too much, to take deep breaths, at least 10 full breaths an hour. So again, atelectasis, fairly benign, can be concerning, but very easily avoidable. So the next condition we'll talk about is acute bronchitis, and I like our little Sweet Pea reference here. Ain't nobody got time for that, and ain't nobody got time for bronchitis either. So acute bronchitis is exactly as it sounds. It's acute inflammation of the large airways of the lung, the bronchioles. 95% of the time it's due to a virus. Someone gets influenza or something of that nature. The rest are due to allergens, so smoke, like in Sweet Pea's example, dust, allergies, and sometimes you can see bacterial infections as well, leading to acute bronchitis. So strep and staph are our most common ones. We'll talk about those more specifically in a bit. And again, it's fairly common. Most people, if they've gotten sick, have a little bit of wheezing, a little bit of this bronchitis. It's 5% of the population gets it annually, but think about 10 million visits per year. It'll spike during flu season. Again, it's most often due to viruses. The good thing is it's typically self-limiting, like most viral infections. Will kind of go away on their own. Patients may have a little bit of malaise, some wheezing. If it's a bacterial infection, sometimes they can have a productive cough, or if it's allergens as well. We talked about those mast cells. But again, it's typically like flu-like symptoms with a little bit of irritation, right? The bronchitis is the irritation of the airways. The chest x-rays are typically normal because, there really isn't, consolidation forming. It's just irritation of the airways. Now, if this gets worse sometimes if the virus kind of progresses. It can lead to what we call a secondary pneumonia. So a pneumonia due to this bronchitis or this infection, and typically we see this in patients, when their symptoms worsen, they don't get better, their cough becomes more productive, and they develop a much more severe fever. Okay, so pneumonia is an acute inflammation of the lungs due to an infection, or really just an inability to keep the lower respiratory tract clean. You can think of it as, an infection or debris or, bacteria that, it gets past the mucociliary escalator. We can't get rid of it's a pathogen, right? So it's either a bacteria, a virus, or a fungus. We can't trap it in the mucociliary escalator. And realistically, again, our lungs are moist, warm, and they're also dark. They don't see a lot of sunlight, hopefully. And that's kind of the ideal breeding ground for a pathogen, especially a bacteria, especially fungi. And what ends up happening is you have this vicious cycle between the immune response that's triggered from this infection. Remember, we've got our macrophages, our neutrophils, and those lower parts of the lung to keep it clean. And when we have this opportunistic infection, there's going to be an immune response. And if it's continuing to proliferate, we're going to constantly be in the cycle of infection, immune response, leading to a lot of collateral damage in the tissue, localized edema, and even that the pathogen itself may release some toxins which affect the lung tissue. Now, there are 3 general types: community-acquired pneumonia, which is something that obviously you catch out in the community, not related to healthcare services. And then there's healthcare-associated pneumonias, which occurs at a hospital admission or in up to 48 hours post-admission. So it's something you caught while you were in a healthcare facility, a hospital or a SNF or something like that, a rehab hospital. And then there's ventilator-associated pneumonias. We'll talk about some of those in a bit. So there's some particular strands of bacteria we see this occurring in. I also want to stress that there are some certain people or certain risk factors that increase the risk for developing pneumonia. Really anything that affects the integrity of the immune system. So if you had recent surgery, if you had head and neck trauma, if you're obese, we talked about that in our chronic conditions. Obesity raises the risk, as well as anyone with underlying lung disease has a higher risk for bacterial and potentially even a viral infection. So pneumonitis, I want to mention this. Pneumonitis, which you can hear this conflated, pneumonitis is inflammation of the lung tissue that's not due to an infection or microorganisms. You can see that from animal dander. You can see that from other different conditions. It's not the same thing as pneumonia. They're a little bit different, and they have a different pathogenesis. We're going to spend more of our time talking about pneumonia, but I did want to address that there is a slight difference between the terms. Now, pneumonia, the pathogens that you can see, again, there's 3 types of pneumonias that you'll see: bacterial, viral, and fungal. Now, I've got listed here the 5 more common types of bacterial infections that you'll see. So streptococcus, pneumonia, or we call this pneumonococcus. It's the same thing. Staph, which again kind of grows on our skin, Staphylococcus aureus. That actually accounts for 50% of ventilator-acquired pneumonias. And that makes sense. If you're on a vent, you're going to have exposures from the outside, our flora potentially into your lungs. And if you're on there for a long time, the risk of that goes up. There is MRSA, which is melifluous-resistant staph. That's a big concern in hospitals. Again, where we've been treating infections with penicillin and other drugs, and these bacteria get stronger, right? They're very resistant, can be very aggressive. Pseudomonas are a hydrophilic bacteria. You can also see these in water vents and stuff like that, and potentially even in ventilators as well. The other side of bacterial pneumonias, you can throw it in there, are these aspiration pneumonias, where you develop a pneumonia from the anaerobes, that come with this aspiration. So patients on an NG tube or nasogastric tube or an orogastric tube, patients on an endotracheal an endotracheal tube. People are like ventilated. Patients with GERD who have a higher risk for reflux. And patients with Parkinson's and Alzheimer's, due to some of the dysphagia and altered mental status that occurs with these patients, have a risk of an aspiration pneumonia. And then what triggers a pneumonia is the anaerobes that kind of come along with that aspiration. Then we have viral pneumonias, Haemophilus influenza, the common flu, which we're all familiar with now, adenovirus or Reader. And of course, we're talking about the coronavirus and other different foreign agents that are, we're seeing SARS and stuff like that. These different viruses that kind of live around us. So more and more of these are kind of popping up. And then we have our fungal. So fungal pneumonias are pretty rare. They typically only occur in patients that have a pretty severely compromised immune system. So these are patients that are, maybe post solid organ transplant, heart-lung transplant, any organ transplantation where we're trying to suppress the immune system, as well as patients with HIV or AIDS, where the immune system is compromised. Now, you might also see mycoplasma pneumonia, which is also known as walking pneumonia. It's similar to a bacterial pneumonia. It's caused by mycoplasm, so it's a little bit different. Mycoplasms, different organism. Very similar to a bacterial pneumonia, but just a little bit different. This is what we refer to often as walking pneumonia. That's the pathogen responsible for that. Now, I do want to stress this because, especially we're in kind of the era of the coronavirus. There's a lot of things that we can do to mitigate the risk of contracting any type of pneumonia, viral or bacterial. Get your flu vaccination, prevent what we can already prevent, or at least decrease the severity, expose your immune system to this pathogen so it can prepare antibodies and get ready to fight it. Our annual flu vaccinations, critical. Clean your equipment, especially respiratory equipment. Good hand washing technique, at least 20 seconds of hand washing. It could be the happy birthday song 3 times, happy birthday to you, or the ABC song, A, B, C, D, E, F, G, like that song twice, 20 seconds. Not hard, 20 seconds to save yourself and a lot of other people a lot of complications. If you do have a risk for aspiration, especially if you have GERD, it's probably a good idea to stay in a semi-recumbent position. This goes for patients with NG and OG tubes. You don't really want to lay them flat, and you want to avoid overfeeding. That's a big thing, big concern there. Also want to avoid consuming alcohol really late at night due to what it does to the gastric system, as well as weakening the upper airways. So you want to practice good dental hygiene, brush your teeth to decrease the risk of colonization in the upper airways. That's why you see a lot of dentists now will prescribe antibiotics prior or even or the perioperative state if they do dental work, because there may be colonization of bacteria that you want to keep those clean. Don't touch your face and hands with unwashed hands. Keep your hands clean, and don't touch your face with dirty hands. Can't stress it. Don't eat with dirty hands either. And live a healthy lifestyle. The biggest thing we can do to kind of lower the risk outside of vaccinations is to stay healthy. Good sleep, good diet, stress reduction, exercise. These are all really good things. Being active helps keep our lungs clean. We talked about that. The best pulmonary hygiene is moving around, right? Ventilating those lungs, varying the tidal volume, varying the pressures of breathing. It's really good. It's actually the first line of treatment for most pneumonias, is just being active. So basically all the things your parents and grandparents told you as a kid, wash your hands, brush your teeth, don't touch your face, are the steps you should just be following for pneumonia prevention. You should be doing this anyway. Now, there are some specific phenotypes that we observe with bacterial pneumonias. So the first being that the symptom presentation is going to be abrupt. Again, we're talking about a microorganism here, a bacteria. They're going to spread pretty quickly. The symptoms are be a fever, malaise, and a very productive cough. It's going to produce a lot of purulent mucus, right? A lot of mucus. They're going to have some wheezes, some of those rales, decreased breath sounds over the area of the infection. And the key differentiating factor between bacterial pneumonias, or one of the key differentiating factors, it's going to be segmental, right? We're going to see infiltration and this, colonization, if you want to think of it that way, in one particular segment of the lungs, typically, right? So it's going to be lobular or segmental. That's not going to be diffuse like its cousin viral pneumonias. So in here we see the right middle lobe, again, right side, left side, consolidation here, reflective of a bacterial pneumonia. The diagnosis, the type, which will help us determine the treatment. We'll have the patient do a sputum culture, determine like what organism is going on there or causing this pneumonia. The treatment, of course, is antibiotics. That's how you kill bacteria. Now, there are 4 stages of a pneumonia. This is typically in reference to a bacterial pneumonia. There's a congestion stage, red hepatization, gray hepatization, and resolution. So congestion phase is also referred to as a consolidation phase. Basically what happens is we have all this exudate, which is high protein exudate, appear and form in the area of the infection, which forms a consolidation. So the area of the lung, which would normally be soft and supple, is now hardened due to the swelling and the exudate in that segment of the lung. So again, remember our lungs usually sort of squishy and soft, depressible. It gets filled with this exudate and forms a consolidation. It gets firmer. And this happens within the first 24 hours. Now, as the pneumonia continues to progress, it goes to the next stage called the red hepatization. Basically, what happens in this stage is the pneumonia causes the lung to have the consistency of the liver. You guys remember what that looks like? It's red. It has this kind of like weird feeling to it. And it's just because the vasculature in the lungs in that region are just overly dilated. There's tons of fluid in there. There's a neutrophil influx. Red blood cells that are filling in the alveolar space as well as fibrin. The lung looks more like a liver or hepatization. Remember, hepato is reference to liver. And then in stage 3, which happens 2 to 3 days after the hepatization, we have a gray hepatization. So no more new red blood cells are present or extravating, they're lysing. And most of the red blood cells in there have been eaten up by the macrophages. So there's still this kind of firmness in the lobe. It's starting to kind of resolve. The macrophages are starting to kind of eat up the degraded red blood cells. Things are breaking down, it's starting to resolve. And then the resolution stage is when the debris, the neutrophils, the bacteria, all that collateral damage is starting to be cleared. Macrophages are still entering to remove the remaining of that debris, and there's now this restoration, remodeling of the pulmonary architecture. So again, there's 4 phases. Congestion first, there's like a ton of exudate, followed up with an engorgement of blood, creating this liver-like consistency in the lungs, all that exudate, hyperemia, that eventually gets cleared. There's red blood cells lyse and die. It becomes this gray appearance. And then there's the resolving period where now we have macrophages coming back in and cleaning up all the debris and restoring the normal pulmonary architecture. Now, there are viral pneumonias, which are a little bit different than their cousin bacterial pneumonia. So viral pneumonias, the onset's a little bit more gradual, and it can be depending on the strand. Like influenza, it's over a couple days. Coronavirus, which is getting on the topic of everyone's discussion, they didn't become symptomatic until like 10 days after being infected. So it'll vary. It's a gradual progression, typically, of symptoms, but every organism is a little bit different. Now, their symptoms are going to be very flu-like, right? Coughing, with very little production. Again, it's not the same kind of organism here. It's these diffuse changes occurring in the lungs. You can think of a little bit of inflammation. So you'll see these diffuse airway changes, some interstitial markings, maybe some atelectasis if there's a little bit of excessive fluid in the lungs, creating some compression on the alveoli. But otherwise, this is something that's self-limiting. We don't really give patients medications for these unless it becomes something more severe or they develop an opportunistic infection. It's symptomatic or supportive treatment. Staying hydrated, addressing the fever if it's present, and antivirals if it's really severe, and oxygen therapy if it's needed. So again, viral pneumonias, you can think flu-like symptoms. It's because usually what ends up happening, someone gets infected with the influenza virus or some other kind of virus. Influenza is a type of virus, and if it affects the lungs, they develop a viral pneumonia. Remember, pneumonia is just a word for some sort of irritation, right, or inflammation in the lungs due to an infection, right? So, in some patients, if they have very severe infections, or there's other causes too, they can develop this condition called bronchiolitis obliterans, or OB, which is an acute inflammatory injury which destroys the bronchioles, okay? Again, there can be a lot of different causes to this condition. Pneumonias can be one, toxic gas exposure, different collagen disorders. Remember, there's a lot of collagen within our bronchioles. Patients with chronic bronchitis. We also see this as a response sometimes to an organ transplant, most notably lung transplantation. We think that's part of the rejection process in some patients. And in pediatric patients, it's something we see after a very severe, very, very severe lower airway infection. So characteristics of what they present with will be dependent on what's the cause of the bronchiolitis obliterans. And again, you can think of it breaking down the root word bronchiolitis, inflammation. Right, so there's my little guy. Inflammation of the bronchioles, and they are becoming obliterated, destroyed. Okay. So what ends up happening is we actually see hyperinflation on the chest x-ray, in the lungs, because of some of the damage, the air trapping that occurs potentially with this destruction of the upper airways. You might hear on auscultation during this immune response, inflammatory response, there's going to be wheezing and maybe even some crackles. They may have a little bit of a low-grade fever depending on the cause. And of course, they're going to have some dyspnea, especially kind of on exertion if they're really pushing it as well. It'll be an insidious onset, and again, it's usually secondary to some other condition. Pneumonia is being a big one, and then in terms of pulmonary conditions, lung transplantation. Now, there is also a kind of a subsegment of bronchiolitis, which is called cryptogenic organizing pneumonia. Again, it's like cryptogenic just means a disease of obscure or uncertain origin, so we're not really exactly sure of what the cause is, but due to these changes, these interstitial lung damage, we end up developing a pneumonia, developing this immune response kind of diffusely through the lungs. So this is again, it's an obscure origin. We don't really, it's a potentially an idiopathic origin. Signs and symptoms: they're going to have a non-productive cough, dyspnea, low-grade fever, and malaise. Again, this used to be called BOOP, bronchiolitis obliterans organizing pneumonia. The term now has changed to cryptogenic organizing pneumonia. And again, this is a pneumonia not due to a known cause with this presence of this bronchiolitis obliterans. Now, we'll wrap up here, and then we'll move on to some few other conditions, some pleural conditions, and then and then we'll get into the rest of our acute conditions. Thank you.